Hello friends, welcome back to my YouTube channel. In this video, we'll be discussing the prostate gland, the anatomical position of the prostate gland, the blood supply, nerve supply, and the clinical implication of the prostate gland. But before we continue, if you are new to my YouTube channel, support me by subscribing and share this video with your loved ones. Thank you and God bless you. The prostate is simply the largest accessory gland in the male reproductive system. Its job is to secrete proteolytic enzyme into the semen, and this proteolytic enzyme breaks down clotting factors in the ejaculate. So the breaking down of this clotting factor prevents the ejaculate from clotting, thereby making it to remain in its fluid state. As the ejaculate remains in its fluid state, it will be able to be conveyed to the male reproductive tract for process of fertilization to take place. As for the anatomical position of the prostate, it is positioned inferiorly to the neck of the bladder and superiorly to the external urethral sphincter, with the levator ani muscle lying inferiolateral to the gland. At the posterior part of the prostate, the ampulla of the rectum is located. This anatomical arrangement is utilized during digital rectal examination, allowing physicians to examine the prostate gland. It is through the prostatic ducts that the proteolytic enzymes leave the prostate. These prostatic ducts open into the prostatic portion of the urethra through 10 to 12 openings at each side of the seminal colliculus, or you call it the verumontanum, secreting the enzymes into the semen immediately before ejaculation. As for the anatomical structure of the prostate is commonly described as being the size of a walnut. Roughly 2/3 of the prostate is glandular in structure and the remaining third is fibromuscular. The prostate gland is surrounded by a thin fibrous capsule. This is not a real capsule. It is rather resembles the thin connective tissue known as the adventitia in the large blood vessels. Traditionally, the prostate is divided into anatomical lobes, which includes the inferior posterior, inferior lateral, superior medial, and anterior medial. It is divided into these anatomical lobes by urethra and the ejaculatory duct as they pass through the organ. However, more important clinically is the histological division of the prostate into 3 zones. These zones include central zone, transitional zone, and peripheral zone. The central zone surrounds the ejaculatory duct, comprising approximately 25% of normal prostate volume. These ducts of the glands from the central zone are obliquely emptying into the prostatic urethra, thus being rather immune into urine reflux. As for the transitional zone, it is located centrally and surrounds the urethra, comprising approximately 5 to 10% of normal prostate volume. The glands of the transitional zone are those that are typically undergone benign hyperplasia. Benign prostatic hyperplasia is one of the clinical importance of the prostate. It is the increase in size of the prostate without the presence of malignancy. Benign prostatic hyperplasia is much more common with advancing age, although initial histological evidence of hyperplasia may be evident from much earlier ages, less than 40 years old. The enlarged prostate may lead to the compression of the urethra, resulting in symptoms that refers to the impaired storage of urine and symptoms that refer to the impaired voiding of urine. As for the symptoms that refer to the impaired storage of urine, they include urine frequency, urine urgency, and nocturia. And as for the symptoms that refer to impaired voiding of urine, they include difficulty in initiating maturation, poor stream, intermittent urine stream, and terminal dribbling of urine. Benign
Prostatic hyperplasia is usually caused by hyperplasia of the glands from the transitional zone of the prostate. Now let's talk about the peripheral zone. The peripheral zone makes up the main body of the glands, which is approximately 65% and is located posteriorly. The ducts of the glands from the peripheral zone are vertically emptying into the prostatic urethra. That may explain the tendency of these glands to permit urine reflux. That also explains the high incidence of acute and chronic inflammation found in these compartments, a fact that may be linked to the high incidence of prostate carcinoma at the peripheral zone. The peripheral zone is mainly the area felt against the rectum on digital rectal examination, which is of irreplaceable value. The next zone, which is the fibromuscular stroma, is situated anteriorly in the gland. It can also be referred to as the fourth zone by some people. This fibromuscular stroma emerges with the tissue of the urogenital diaphragm. This part of the gland is actually the result of interaction of the prostate gland budding around the urethra during prostate embryogenesis and the common horseshoe-like muscle precursor of the smooth and striated muscle that will eventually form the internal and external urethral sphincter. The prostate, as we know, is a living part of the body, and definitely we have blood coming to it and as well living to it. Therefore, let's talk about the vasculature around the prostate. The arterial supply to the prostate comes from the prostatic arteries, which are mainly derived from the internal iliac arteries. Some branches may also arise from the internal pudendal and also the middle rectal artery. As for the venous drainage, the prostate is drained by the prostatic venous plexus, draining into the internal iliac veins. However, the prostatic venous plexus also connects posteriorly by networks of veins, including the Bastings venous plexus, to the internal vertebral venous plexus. The prostate also has nerve supply. So let's look at the nerve supply of the prostate. The prostate receives sympathetic, parasympathetic, and sensory innervation from the inferior hypogastric plexus. The smooth muscle of the prostate gland is innervated by the sympathetic fibers, which activate during ejaculation. The prostate is sided by the two neurovascular bundles that travel through the pelvic floor towards the P structure, supplying it with nerve fibers and blood vessels for the corpora cavernosa. The integrity of these bundles is critical for normal erection. During surgery for prostate cancer, which is known as radical prostatectomy, damage is often inevitable to one or both of these bundles, resulting to impairment of erectile function. Special nerve-sparing techniques may prevent extensive damage to these bundles, therefore allowing for post-protective potency. An important clinical correlate of the prostate is prostatic carcinoma. The prostatic carcinoma represents the most commonly diagnosed cancer in men, especially in countries with high socio-demographic index. The malignant cells commonly originate from the peripheral zone, although carcinomas may arise from the central and transition zones too. It is still debatable that the later tumors may present with lower malignant potential. The proximity of the peripheral zone to the neurovascular bundle that surrounds the prostate may facilitate spread along the preneural and lymphatic pathways, therefore increasing the metastatic potential of these tumors. Malignant cells may invade adjacent structures such as the bladder and the seminal vesicles, and other structures like the lymphatic and blood vessels to give distant metastasis. Prostate carcinoma also commonly spread through Bastings venous plexus to the vertebral bodies and cause skeletal metastasis. A digital rectal examination may reveal a hard, irregular prostate gland. In most cases, the serum PSA values will be increased. However, due to the peripheral advancing tumor, symptoms may be minimal, as obstruction occurs usually at late stages. One should also keep it in mind that the high incidence of prostate carcinoma is found in elderly men who may already have symptoms during the benign prostatic hyperplasia. The next clinical correlate is the prostate specific antigen. The prostate specific antigen, abbreviated as PSA, is an enzyme secreted by the prostatic epithelium that aids in the liquefaction of the ejaculate by lysing the seminal vesicle proteins. This enzyme is the serine protease. However, the main clinical use of prostate specific antigen is a tumor marker specific for prostate carcinoma. Increase in level of serum prostate antigen may suggest the presence of prostate cancer. Nonetheless, other conditions that may irritate the prostate, such as the inflammation and severe constipation, extended sexual act, or catheterization, may also increase the prostate specific antigen levels in serum. Thank you so much guys for your time. I hope this video will help us in understanding prostate anatomy and also to understand prostatic cancer. See you guys in the next video. Please remain peaceful and always do the right thing. God bless you. God got you. Peace.